Hello. Now I'm very happy to introduce the second speaker in our session about digital health. She's the director of the Institute for Preventive Medicine at the University Hospital here in Lausanne, at the University of Lausanne. Murielle Bochud, epidemiologist. That means a little bit, again, far away from our topic of the brain, but she will try to convince you and us why also taking care of other systems and organs, it's important to understand and maintain brain health. Thank you very much, Murielle. The stage is yours.
Thank you, Bogdan. Thank you for inviting me to give this talk. I am a public health physician and an epidemiologist. And the title of my talk today is Population-Based Data to Facilitate Health Promotion, Prevention, and Clinical Diagnosis Related to Brain Health. Although, as Bogdan said, I'm not a specialist of brain health measurements. We know that there are important regional differences in regional mortality in Switzerland. You see here maps for cardiovascular disease, diabetes, stomach cancer, hypertensive disease mortality. What we can see is that the situation may be very different across diseases. So we know that this is due in part to behavioral factor, or genetic factor, or environmental factors. Here is another example of these geographic differences. This is a population-based psych-Colas cohort in Lausanne, where you see that there is a geographic clustering of obesity, overweight, obesity, and normal weight. And to get to such picture, you need to have a big enough sample size in a given specific location. The idea, in my view, as a public health physician, is to use population-based cohort to create clinical and public health utility while generating novel scientific knowledge. And it should really be embedded within the routine healthcare system. It should inform public health policies. It should inform primary prevention and health interventions in the population. And it should also help conduct research in health services and systems. Why are population-based cohorts important? First, they provide longitudinal data and incidence data to assess the burden of disease in a given country or region. They have, if the participation rate is sufficiently large, high external validity. You can collect lifelong exposure data. By biosample collection, you can integrate many different types of exposure to diet, to toxic, to environmental exposures. You can assess socioeconomic status and work trajectories, which we know have a big impact on health status and disease risk. The idea is to be able also to link those cohort data to routinely collected data from the healthcare system with medical administrative data, and also to conduct health services and systems research. The idea more and more today within those type of cohort is to have a participative component allowing cohort participant to be involved in the design and also in the return to results to participate. There can be also a health economics component, a spatial epidemiology component, as I just shown you, and also to integrate dietary, toxic, and professional exposures in a systematic and standardized way. And why is it important to have population-based cohort run in Switzerland? We do have fragmented healthcare systems, a decentralized governance, so quite some heterogeneity across canton. We have, at the time being, little crosstalk between cantonal and public health authorities and funding institutions for research. We have barely accessible health insurance data. We do not have an easily usable unique identifier. We have no unified healthcare information system. We have little data on trajectory in any given age group so far within the Swiss context, and we have limited longitudinal data on key exposures. And we also have extremely rapidly raising healthcare costs. And at the time being, compared to other countries in Europe, limited investment on prevention and health promotion. What are the challenges of population-based cohorts? It is usually quite a high burden for participants, and so far participation rates have been quite low. In our population-based cohort, it was a big success when we reached 40% participation rate, but often it's only 25 or even 20%. So the challenge is how to motivate people to participate and how to personalize maybe the phenotype so that it best answers the needs of participants. Privacy protection issues are raising concern for participants and for legislators. It may be quite tricky to set up the governance system. In Switzerland, one of the challenges is a unique ID, the absence of a usable unique ID nationwide. It's a challenge to have a sustainable IT infrastructure, to put in place a dynamic informed consent, because usually you need to have a follow-up of 20 or even 30 years. It's difficult to maintain this on the long term. And such cohorts, such data collection are very costly. So the business plan and the sustainable funding sources is difficult to achieve. I'm going now to present you a project which is called the Swiss Health Study. It is a pilot phase for a big national cohort in Switzerland. In French, it's called Étude suisse sur la santé, in German, Schweizer Gesundheitsstudie. You see here the website, Étude suisse sur la santé. We are going to focus on pesticides and mercury in a first stage. It is a project that involves many partners in Switzerland, our institution, Unisanté, the SHIV as well, the Swiss TPH, which was instrumental in developing the design. We have the Biobank centralized at the University Hospital of Bern. It is a financing via the Swiss Federal Office of Public Health. We also have contributions from other federal offices in Switzerland. And the idea is for the data collected to be interoperable with the SPHN framework, meaning the Swiss Personalized Health Network Initiative. The idea is to really put in place a project where we can assess a broad range of exposures within the Swiss context, to follow people with time, to measure their health status repeatedly, and to provide key information on the various health determinants, and also to assess the impact of interventions and of the healthcare system within the Swiss context. The concept for this pilot project is really also to include the social context of participants, to build up a cohort and a biobank and the system that allow us to have something which is the same for every canton in this fragmented healthcare system, to put in place repeated investigations, have a long-term follow-up, and to have a very broad assessment of the health status of participants, and to go in the direction of exposome research, where we have a broad assessment of various health relevant exposures. The conceptual framework is really to try to be as synergistic as possible with ongoing initiatives in Switzerland. One of them is the Swiss Biobanking platform, which is setting up all the quality control measurements for biobanks in Switzerland to be aligned with this SPHN initiative, aiming to put the routinely collected hospital-based data as highly interoperable as possible within the Swiss context, to be aligned with NCD strategy, non-communicable disease, and also to be aligned with various European initiatives such as HBM for EU for human biomonitoring. The idea is to reach a sample size of over 100,000 participants in Switzerland. The aims of the national project is to collect health data, to generate Swiss reference values, to better understand the link between the environment and health within the Swiss context, and to support public health policies. We are now starting with a bit of delay because of the current sanitary crisis, collection for the pilot phase. We will collect 500 participants within the canton of Vaud in Lausanne, and 500 participants in Bern, in the canton of Bern, during this pilot phase. We'll assess a broad range of nutrition, professional, lifestyle exposure, and also the health status of participants. This is a random sample of the general adult population. We have decided in this first stage to restrict the recruitment to adults to simplify the ethical procedures. The aims of the pilot are to develop methods, to build up an infrastructure, to check and optimize the recruitment, and to analyze selected parameters to see also the acceptability of the population within the Swiss context. We have spent a lot of time and energy to develop an IT and management and data protection system in collaboration with our university hospital IT system. And as I said before, all these IT developments will be integrated within the Swiss Personalized Health Network Initiative, which is financed by a federal office. The timeline is that we are now starting again the data collection for the pilot phase. We are going to write a report for the Federal Council, which are our highest authority in Switzerland, and we hope to be able to have a national study starting 4 to 5 years from now, if the federal authorities give their approval for the project. I'm now going to talk a bit more about the Swiss Personalized Health Network Initiative, which is a coordinated nationwide infrastructure to promote personalized health and well-being in Switzerland. So the idea is to construct within the fragmented, information system of Switzerland, an big, secure highways to exchange sensitive health-related data in Switzerland. The first step was to ensure interoperability across university hospitals. The next step is to integrate, population-based cohorts and population-based surveys and registries within the system. I am part of a working group which is in charge of cohorts and registries in Switzerland, and to try to put together all the the relevant stakeholders within the Swiss context. This includes as well all universities and high schools in Switzerland who are involved in generating research data. So the idea from a technical point of view is to have a national data coordination centers and to have a decentralized approach. So every group can keep its own data locally, but then we are able to analyze jointly the data because those data are created to be interoperable and shareable and reusable. Within this SPHN framework, with Professor Nicole Probst, Swiss TPH in Basel, we were able, also in collaboration with Bogdan Draganski at the SCHUV, to get a funding for the Swiss Aging Citizen Reference Project, which aims at creating interoperability between the COLAS, SACR population-based cohort, the SAPALIA multicentric population-based cohort, the SCIPOG multicentric cohort, and the SHEES pilot phase that I just presented to you. We have also added a brain health component to this project, in which both COLAS, SAPALIA, and SCIPOG, we will have the same brain MRI phenotype collected, and we will relate this to epidemiologic data to try to assess whether, lifestyle behavior can have an epigenetic signature and help us understanding how this may influence or be associated with brain health phenotypes within the Swiss context. If I go into the Lifecourse epidemiology concept, we have the critical period, which is a very important concept, meaning that if an exposure occurs during a certain very critical period, it may have a different impact than if it happens later on during life. Embodiment is the concept of how extracting factor experienced at different life stages are inscribed into an individual's body functions and structure and may have an impact on their health status and well-being. What is very important in public health and epidemiology are the notions of induction and latency periods, knowing that, induction is a time between exposure and initiation of the disease process. And this is characteristic of a given exposure and a specific disease. And this induction period may last very long. It may last for multiple years. If we take For instance, asbestos, the induction period may last for up to 15 years. So it is important to have very long follow-up during those projects. The latency period is a period between disease initiations and detection, or the healthcare system. So it depends on the disease or on the healthcare system. Then you may have mediating factors or modifying factors. So the mediating factors is really a factor that mediates the association between a risk or protective factor and the disease, and it chronologically follows the exposure, and it's lying within the causal pathway to the disease. And a modifying factor is a factor that will modify an association between an exposure and the risk of disease. Classical modifying effects have been described between smoking and alcohol consumption, for instance. Within the Lifecourse epidemiology setting, we can define different models to describe risk factors. We can have an immediate risk model, a social trajectory model, a cumulative biological model, a sensitive period or latency models, and a mobility effect models. And depending on the model that you postulate, the data analysis is going to be different. But in order for us to be able to differentiate which of those models is best fitting the data, you need to have a longitudinal data collected on a very large number of participants. And it is best when those are population-based data, so that you can have data on diseased people and non-diseased people, and you can compare the risk across those different groups. If we take the specific situation of cognitive function and brain health, you may imagine different life course trajectories, people having between birth and adulthood different levels of cognitive functions and having different ways of having an age-related decrease in this cognitive function. And to be able to assess those trajectories, you need to collect data during the entire life of participants, ideally since conception, even before birth. And you may imagine for any given diagnostic criteria at the same, using the same diagnostic criteria, that you may have different cognitive trajectories across the life course of participants. If you have in the panel on the left a longer period of cognitive development but faster rate of decline, or on the panel B, more severe cognitive decrements after stroke but greater neurologic discoveries. These are very different situations. So here is another example for Alzheimer's disease. You can collect information early on during life that may have an impact on the risk of developing Alzheimer's disease later on. We do know that there are genetic factors that may influence the risk. There are childhood and adolescence risk factor for Alzheimer's disease. But in order for us to adequately assess a link between those early onset factors and the adult disease risk, we need to collect lifelong data. I'm going now to briefly present some results of a UK Biobank, this well-known population-based cohort in UK. It was initiated in 2006, and 4 years later, they had collected high-quality data on 500,000 participants. You see here a picture of all the different phenotypic data that have been collected, and this includes brain MRI, for instance. The advantage of collecting such large-scale data is that for any given disease, let's say dementia, diabetes, coronary heart disease, you will have several thousands of incident cases that you can study the link between exposure and lifestyle behavior and get very robust estimations for men, for women at different age groups, to compare regional differences and so on. An interesting result that was published lately is to show the benefit of high-intensity physical activity to decrease all-cause mortality within the UK setting. So we all know that regular physical activity is good for health, but what was not so clear is whether for a given volume of physical activity, it's better to have low intensity or high intensity physical activity. And what the UK Biobank data clearly showed is that at a given volume, it is better to have high intensity physical activity than only low intensity physical activity. So these may have important implications for public health messages and for health promotion intervention in the population. An important limitation of the UK Biobank data is that the response rate was only 5.5%. So this unfortunately limits the external validity of those findings, and we may think that those who took part to this project are rather more health conscious than those who did not. Recent findings in terms of exposomics and genomics is that polygenic risk scores that are now easily generated from genome-wide association studies are now starting to show clinical utility for common chronic diseases, meaning that we can combine classical clinical risk factor for cardiovascular disease, for instance, such as lipid, smoking, high blood pressure, with polygenic risk scores to better combine and stratify participants according to their risk and to identify, for instance, the absolute risk of coronary artery disease. What can you do with this? You can stratify the people according to their genome-wide polygenic risk score. And if we look at those percentiles of the polygenic risk score, you see that the prevalence of coronary artery disease between those who are at the low risk goes from 2% to 10%, just on the basis of this genetic information that is present since conception. So this is a way to capture lifelong exposure. Using UK Biobank data, investigators was able to show that we can generate similar risk scores for atrial fibrillation, type 2 diabetes, inflammatory bowel disease, and breast cancer. So it's really, really useful for a broad range of common chronic diseases. Here, it's another example for cardiometabolic disorders, where we can see that depending on which level the participants are for this polygenic risk score, their lifelong risk of getting type 2 diabetes, atrial fibrillation, or a congestive heart disease can be really very different. Here, an example for obesity. I was really surprised by this result because it's also using UK Biobank data, where you can see that depending on your polygenic risk score for obesity, you can have a difference of weight at middle age, which is of 13 kilograms. This is really major. So the prevalence of obesity across the deciles of the polygenic risk score goes from 9% to 37.6%. So this is really a huge difference, showing that we are not all equal with respect to the genetic risk of becoming obese. Recent findings have also shown that such polygenic risk score can modify the penetrance of monogenic variants. And if you look at the probability of coronary artery disease by the age of 75, even the person, if the person carries the hypercholesterolemia variants, non-carriers or carriers, it really modifies the lifelong risk of getting coronary artery disease. So my last example will be about recent findings linking kidney function, which is of great interest to me, with cerebrovascular disease, in particular stroke, when genetic information, in particular genome-wide association, genome-wide polygenic scores, allowed showing that there is a pleiotropy, meaning that there are shared genetic variants between chronic kidney disease and stroke risk. And so that this highlight the fact that there are shared mechanism, pathogenic mechanism between kidney disease and cerebrovascular disease within the general population. And this shows the usefulness of using genetic information for causal estimation. In conclusion, large-scale population-based studies provide valuable insight into disease frequency, incidence, risk, and protective factors. A Lifecourse approach is important to identify targets for early preventive interventions. Genetic variants are present since conception and allow capturing risk of disease long before disease onset. Genome-wide polygenic risk scores aggregating millions of genetic variants are now reaching clinical utility. And high-quality phenotypic data are of key importance to maximize the benefit of population-based data. And publicly funded data need to be findable, accessible, interoperable, and reusable. Thank you for your attention.
Thank you very much, Murielle. I have to rush now to my own presentation. Speak to you in a second. Again, virtual applause for you. Speak to you in a minute.
Thank you.